Hello and welcome to another Down Fracture podcast, a podcast for talking jaws. Per usual, Dr. Michael Wasson here with Dr. Sam Bobek. Sam, how was your fourth?
Oh, it was great. Um, Friday, 4th of July and the normal weekend, it was just one big weekend of barbecue and outdoor time. I went to a baseball game yesterday. It was great. What'd you do?
We were in Alaska
Oh yeah.
to visit some family. We also went to a baseball game there. It's kind of an interesting summer league they have there. Are you familiar with that one?
No, you sent me that picture. It seems like some pretty big name people play up there.
Yeah, it was interesting. So I didn't know about it to be honest, because it's not minor league baseball. It's apparently like a collegiate summer league where they can, like, collegiate players can go play, but yet maintain eligibility. And so it's kind of cool because I
That is
mean,
cool.
you're seeing some decent baseball, and I will say they definitely swing the bat more. Like you can tell that it's maybe not as competitive in the sense of like, hey, I'm here to have a great batting average. It's like I'm here to get some cuts on the ball and I'm
Yeah.
here to
They
try
wooden
out some new
bats? Are they
pitches.
using wooden bats or metal bats still?
Wooden bats.
Yeah, good.
Or wait, I think it was wooden bats. Now that you say that, I'm less certain. I'll have to look into it. But it was cool. Alaska's nice, good
Yeah.
weather, some mountains, saw some moose.
Yeah, that sounds like a great trip.
Well, yeah, so otherwise, downfracturepodcast at gmail.com. We did get some feedback after the last episode, which was nice. Some people with some feelings on patient-specific implants and custom hardware for orthognathic surgery, mostly from smart people who agreed with us, which is always refreshing to get that reinforcement and support. But then today we're going to touch on mandibular midline osteotomy and orthognathic surgery. Is that correct?
Yeah, that's my understanding. We had I think a few requests over whatever period of time, the months of people suggesting topics. And this is one that's come up a few times. So midline osteotomy of the mandible. When did you get introduced to segmental mandibular surgery?
Well, I'm glad you asked me that, Sam. Um, Actually, on the screen here, I have an article that people might want to reference for all of the viewing audience. If you're just listening, the article is called Mandibular Narrowing Advantage in Transverse Problems, and it's by Dale Bloomquist, who you and I both know, who trained me and who exposed me to this technique during residency. And this article was in JOMS back in 2004. Um, so that's when I got exposed to it. And the way I was exposed to it was in the sense that this was utilized mostly for transverse correction when there's otherwise an ideally positioned maxilla. And so pockets across the country don't seem to utilize this, and others tend to utilize it more. But that's how it was kind of brought to my attention was, hey, tooth show's good, maxillary position's good. We're trying to minimize surgery or keep this to one jaw because otherwise we just need to correct the transverse. So let's do a mandibular midline osteotomy. And mostly what I was exposed to was narrowing, and not much widening that I can recall in residency, but it of course could be utilized for both purposes. What about you? When did you get turned on to that? Did you get exposed to that in residency? Because it's not everywhere.
Because yeah, I don't know if I did any in residency. I know we did a handful, like just a one or two in fellowship. Um, it didn't become honestly part of my planning. I had heard a lecture from Simonis Grabakis. He's a European oral surgeon. He does a good bit of jaw surgery. He's a good person to listen to. Um, at one of the winter meetings, I think ACOM's winter meetings, he gave a talk on face shape and midline osteotomy of the mandible. And I don't know if that came before my moving to Seattle or if those happened at roughly the same time. And just both of those events caused me to start utilizing this. Because in the move from Portland to Seattle, which maybe 11 plus years ago now, when I came up here, it was just the culture to do midlines. And so people asked me about it. Like orthodontists would ask me about it, at the hospital. I would get questions from the techs, those sort of things, like, "Oh, you're doing a midline, do you do it the same way that Bloomquist does it?" And I kind of learned indirectly from the knowledge that's existed, because that was kind of one of Dale's things, right? Like doing the midline osteotomy of the mandible as kind of a routine management strategy of the transverse. And so I think that's kind of how I got exposed to it, honestly. It makes sense in 3D land to segment the mandible in situations of asymmetry, or just to manage the transverse if you want to keep it to a single jaw. But it also makes sense in terms of face shape and that sort of thing as well. And so I tend to use it. Um, I think of it frequently in terms of the treatment. So I forget that it's weird here in Seattle, and that it's not something that other people may be as exposed to. So
Yeah, when I talk about it with some people, they just look at me like, "What are you talking about?" And I work with some of the residents down here and was talking to them about it, and they haven't seen it, so they're going to do some with me in the near future to hopefully get some exposure to it. I would also throw out another indication that kind of coincides with everything that we both just said, and I think we've mentioned this before of having multiple plans or having other bailout strategies. And, this is one that can be useful if you need a large expansion and you think, man, I'm really pushing the limits in the maxilla. Maybe I won't expand 15. Maybe I'll expand 10, 11, 12, and narrow the mandible to coincide with that as ways of averting risk. Or, as you said, maybe the face changes that would come from such an expansion might not be favorable depending on the patient's age and gender and face shape, and can be utilized in that manner too.
yeah, I mean, I think there's a lot of indications for it, but it's kind of getting over the initial hump of, hey, what's midline like? Like how do you do this? When would be the easy cases for it and that sort of thing. And so I think we probably start there, right?
Yeah.
Do you use this in your treatment planning now?
Say that again.
Do you use midline osteotomy of the mandible as part
Oh,
of your
yeah.
treatment planning?
Yeah.
I guess
One of the
not.
images on the screen is for an upcoming plan. I don't do it probably as much as I should, to be honest. I kind of probably fall into the trap or the philosophy that most people have, in that, hey, if I'm doing the maxilla, I'm going to correct the transverse there most of the time, and maybe I don't focus enough on face shape or other things to where I could bring this out of the toolkit a little bit more often. But it's definitely in my repertoire. It's something I'm comfortable with. It's something I've done a number of times, and got exposed to 15 years ago, or not 15. Wow, that's you. 12,
Easy.
13 years ago. And, it makes a lot of sense. And I wouldn't say I've done so many that I feel that I'm the person to ask about this, but I feel like it doesn't have a lot of complications, other than the typical things you might think of having to make an incision to get access to this area where you can get witch's chin and other things depending on your incision type and closure and complications or other things that can go astray. But in the maxilla, you worry about transverse collapse, relapse, blood supply, splints, you know, having things in multiple segments. But I haven't found, again, with my numbers probably being lower than yours and others, I haven't found that I get a lot of issues in when I do this. Is your experience similar? Or have you?
Well, yeah, can I share my screen? I have a 3D mandible
Yeah,
up.
go right ahead.
I think it's useful for kind of discussing this stuff in general. Um, is this thing up?
Yep, I can see it.
Great. Yeah. So, I mean, what do you bring up in terms of people's comfort with segmental maxillary surgery? Segmental maxillary surgery is a good starting point to understand segmental mandibular surgery. Um, because I think in midline mandible, there's a question about distraction versus just doing segmental mandible. And it's exactly the same concepts as a Sarpi or a segmental Lafort, right? Like you do a two-piece, a three-piece segment Lafort, you're making those cuts between the teeth where there's space. You're expanding the arch where you need the expansion. The same all applies to the mandible, right? So while we say midline, you don't have to go between the central incisors. I mean, if there's not space for the cut, then it's fine to go off the adjacent teeth. I think a tidbit on that is generally, it's a good idea to step it to midlines. So here's this picture's up is a just a straightforward midline osteotomy with a sagittal osteotomy. And I think in this situation, he's widening and advancing at the same time. And so, in terms of the lower jaw movement, not get too caught up in that. But in the most straightforward pathway, the process of doing this operation is different than Lefort, but it's the same philosophy as doing a segmental Lefort. So I think a lot of questions in terms of how this goes about is, just how can we technically do it? I think what I learned over the years is to start by opening the chin. Correct me if I'm wrong on how you approach it, but generally it's start by opening the chin. And the reason for that is dissecting the chin is a lot easier with the condyles attached than it is after you've completed both the splits. So um,
That's not the way I was trained, but makes
you
sense.
you dissected after doing you did right sag, left sag, midline.
Yep.
Yeah, so maybe that was something from fellowship then, because I know Tucker talked about those things and Farrell sprinkles in midline. So maybe it was a combo between those things. But dissecting off the soft tissue of the chin just makes it exposed, and then you start with the cut. And from a normal genio incision, you obviously can't see between the teeth, so you make the cut about as high as you would for, let's say, a segmental Lefort cut, right? Like an interdental cut. And you just don't complete it though. And then do the right sag, split it, do the left sag, split it. And then place the intermediate splint or your final splint, either one of those two things, and put them in loose IMF. Am I now in line with what you're doing? Is that
Yep.
similar? And you
Yep.
put them in light at IMF because the mandible can slip out of it, and it becomes this like mandible that just sits back too much when you're trying to make your cut. So you apply pressure with the saw, and it just, it's not attached to the condyle, so it can be a bit of a moving target. And so, oscillating saw to complete the cut at midline, and it's very similar. J Freer to distract retract the gingiva superiorly. You want to maintain the lingual mucosa. I think that's probably the hardest part of it, um, because cutting through the mucosa has the same kind of blood supply effects as it would in a fort. Um, and once it's mobilized, it just kind of seats into the splint. So when you widen it out, it seats in the splint. So there's times like in this situation where I'm advancing and widening the lower jaw, where sometimes a lingual splint can be helpful. But I think oftentimes, correct me if I'm wrong, Dale didn't use a lingual splint, right?
Not that I ever saw.
Yeah. So,
It
but I
might have
mean, I,
been.
I do like them when I'm doing advancement and widening in the lower jaw, just because I think it's useful to prevent the tipping of segments. Um, so let me take a step back. So once you make the cut at the midline and you allow the lower jaw to widen, the forces to widen the jaw will be wires, even if you use embrasure wires, embrasure wires, vertical force, but it'll want to tip these segments. So I feel like I'm doing TV on a football game here, but these segments will want to tip in, which rolls the inferior border out, right? And generally, I think I can seat all the buccal cusps, but it's easy to not get as much expansion at the lingual. So it's in that situation that I think a lingual splint can be helpful. Am I making sense, Wasson?
Yeah, you're making sense to me because I can
Okay,
see the
yeah.
screen and I'm kind of familiar with it.
And so, if you need to hold the splint, doesn't matter. And then you finish the fixation at the chin. So you put the fixation, just like you're doing a symphysis fracture, you put positional screw, you can do lag screw technique, do positional screws, you can put two plates in. If you do one plate, just you'll have to use the braces as the tension band. None of this is new for anyone listening to this. But once you fixate the midline, then it's really interference fest. And so my understanding of why mandible forward, mandible narrow was the common intervention had to do with it helped manage interferences, right? Because mandible forward, mandible wide is a ton of lingual plate interferences. Like these are definitely in the way. Um, it's but I think in the situation of like airways now, I think it's probably going to be difficult to find people who are okay with mandible forward and mandible narrow. From face change, I think that's a good consideration. I think also just from, simplifying orthognathic surgery, I think it's a good combination. But from the lingual interferences, I would just throw out the tip of managing those before you get to the midline. So I think if you're advancing and widening at midline, it's going to be a bit of a harder operation. So you just need to be comfortable managing those interferences before it happens, because for sure, that those interferences can block your ability to widen the mandible. So
Yeah, makes sense. I mean, you run into that just advancing, a decent amount, and if you're widening that in conjunction, going to be a ton. So let me back up. So what incision do you make to access the midline? Do you do the typical symphysis access out in the vestibule,
yeah,
dissect through the
just
talus,
yeah,
or do you go straight down at the
just a
depth of the
genio
vestibule?
incision.
Because well, I think that means different things to different people.
Oh
Because
yeah, okay, you're right.
because what I was trying to do with Dale and Gary is they just basically made their incision at the depth of the vestibule for this and for Genio. Like they just went straight down to bone at the depth of the vestibule. They
Huh.
didn't do the typical out in the two skin hooks, double-ended skin hooks, retracting the mandible, cutting out in the lip, and then taking the incision down through the mentalis into bone, and then resuspending mentalis as part of your closure. They didn't do that. They just went straight at the depth of the vestibule.
Yeah,
Uh,
huh. Yeah, and I mean, I think the chin technique is definitely one that I picked up in fellowship from the Charlotte guys in terms of making an incision in mucosa and the lip, and then formally dissecting out the mentalis, cutting through it so you have a good cuff, and then having a secondary plane of dissection down to periosteum, the incised periosteum, dissect that way. I just do it that way. I mean, I think when you get into fancier segmental mandibular surgeries, there's definitely a problem of tearing the mucosa, not only on the lingual side, but in the interdental space. Because one of the big problems of midline or paramidline or even midline distraction of the mandible is there's just not as much gingiva or not as much bone around these small teeth, like you're dealing with mandibular central incisors versus maxillary incisors, and it's just different quantities of things. So smaller bones, smaller teeth, smaller gums. So you just got to be kind of more careful with it. So I got to believe that having more tissue there is better.
I would think so.
But I mean, I think however people address it, I think with narrowing. So with narrowing, how do you get rid of the interferences? Because with widening, there's not going to be an interference, or if there is, it's out here on the facial.
You mean at the midline interference?
Yeah,
I don't think that I've ever actually done anything. I think we just cut it and it pivots off itself, fits into the splint reasonably well. I can't recall having ever really done much in the way of midline.
just kind of accept flaring of the segments,
Yeah,
because you would have the opposite from below, right? Like with
right.
narrowing, you would
You get the
expect it to be
line
the
from where we
opposite
talked about.
triangle.
Yep.
Uh, and
You
so
you
I
do
don't know
that?
what
You
the
remove bone on the lingual to help compensate for that?
Well, yes. I mean, I think the things that I've seen on that one is Fisher burr through the osteotomy site, like using a Fisher burr. I think now I just tend to cut it again with the oscillating saw, like just put it in the splint and then just cut it and then just keep cutting it until there's no interference. Kind of like treat it like a subapical for impaction. But I would, I don't know. I think generally with narrowing, I'm more of a camp of dropping a chin, because the ability to do a genioplasty here takes the whole chin segment out of the narrowing of the mandible. So I don't know. Nowadays, I think if I'm narrowing the mandible, I think I I try to make it easier, because that's a hard thing to fix, right? Like narrowing the mandible, it definitely has lingual interferences, and so advancing the chin or removing the chin segment separate from it can be helpful. So I think with midline, normal fixation of the mandible, um, the rubber bands afterwards can cause tipping of the segments, and so I feel like a lingual splint again can help you out maintain the width. This is obviously depending on what kind of fixation you have, but I've definitely seen segments rotate in, and it's very managed in the same way as segmental maxillary surgery, which is like cross arch elastics or keep the splint in longer. So those sort of things. In many ways, I think this is much easier than a segmental afford.
How are so if you're keeping a lingual splint in and let's say you've widened the maxilla at the same time, you keeping a lingual splint in and a palatal splint in, and are patients tolerating that okay?
For widening both arches at the same time, I pretty rarely keep both splints in. So the widening the upper and lower arches is kind of a different concept that I wouldn't say that should be your first midline osteotomy. That's a complicated surgery in general. Um, but these days I generally just have it there to use it. But it's pretty uncommon to use a lingual splint. Whereas segmental maxillary surgery, it's like an always thing, you know.
Mhm.
So I don't know. I think that the other indications in terms of face change in my neck of the woods, more tapered face shape is very aesthetically pleasing. In Korean patients, Southeast Asian, the the midline can really help you out in treatment planning that crew. Gender affirmation, those sort of things. More of a feminine face for more taper, more of a wider face. If people have those aesthetic preferences, segmental mandibular surgery is a good tool to use. So um, I think it's just finding the cases for it. So uh, I don't know.
What complications have you run into, if any? I mean, other than you mentioned tipping of segments, have you
Tipping
had
segments. I
what should
haven't seen
people
a
be avoiding?
non-union on those yet.
What's
I,
that?
I would assume non-unions happen, but I think it's generally a fixation problem. They tend to heal well. I've seen tooth discolor because you're working around teeth. Um, with multiple segment mandibles, it's a little bit harder occlusion, so it could be a little longer orthodontics, those sort of things. But I think generally the concern that people have has to do with having enough blood supply to the anterior mandible, and then healing issues, both bony healing, but also soft tissue. So
Okay.
I don't know what my experience of this is. It's definitely less than Bloomquist has done for sure, but enough to where I feel like I got a good feel on the different interventions, and it just seems to be more stable than segmental maxillary surgery. And so,
So they what I was trained with was just a single inferior border plate, and
yeah.
the arch wire was frequently cut at the midline. So the plan was usually involving either the patient seeing their orthodontist like a day to three at the most prior to surgery and having a new arch wire placed that would accommodate the narrower position, or they would just cut the midline of the arch wire at the time of surgery and have it replaced down the road and just a single plate at the inferior border. Um,
And so they wouldn't glue the arch wire?
no.
Huh.
Mm-mm.
Yeah, I
So
think
that's
the
always kind of been what I've done for that reason. That's just how I was trained and where I got my reps. And so I usually just use the single plate.
so it'd
But
be a single plate with bicortical screws, the inferior border.
yeah,
Yeah, and I mean, I think it's just coming from trauma experience is why I would probably want some tension band for that. And I mean, if you're using IMF or you're using some level of occlusal fixation, you should be fine. Um, but you're saying you just put it in for your border plate and then cut the arch wire and then let it
they
go.
would either, yeah, they would either cut the arch wire at the time of surgery, or again, they would have like a new arch wire placed just shortly before surgery, so that it wouldn't be enough time to cause dramatic orthodontic changes. So a more narrow wire placed, like sometimes day before surgery, and do it that way.
Yeah, I mean, I
And
think
then
I'm
not,
just generally concerned about stability, but that might be good too. I
yeah,
think,
I don't know. But yeah, I mean, just to kind of go along with what you said, that's how I was trained: is you cut one side, cut the other for the sagittal split, wire them in, when we say loose, I mean it wasn't like they were just flopping all over the place, but
Yeah,
yeah,
yeah.
they definitely weren't wired down completely, but pretty close. And then it was kind of always interesting. I remember the first one I saw, and that when they cut the midline, it almost just like popped into the splint,
Yeah,
like with
exactly.
not a lot of manipulation. And I was like, oh wow, and then just tightened it down a little bit more. And this was all, of course, with um, traditional braces at that time, and then they just bent the plate at the inferior border, put in bicortical screws, rinsed it out, stitched it up. That
Yeah,
was
I
pretty
mean,
much.
I think like in that 3D thing we're looking at, I think feeling the widening, like making sure that it's free and it's not like tethered at the superior border. So I think these days I tend to take them down from that first stage IMF and then feel the mandible to make sure it's freely widening. You know what I mean? And I try to feel if there's interferences proximally. I mean, I don't think that's perfect, but I try to. And then either put in lingual splint or just wire them down completely in the final. Because embrasures help a lot with this. Embrasure wires
Mm.
are super useful.
Yeah, it seems like it would be. I mean, that would be, I mean, the interference thing is kind of interesting to me because I hadn't really given that much thought because that's just again how I was trained is just we didn't really deal with it much at the midline. Of course, posteriorly you have to deal with it in every sagittal split.
But you've
But
had it for like class 3 situations, right? So you're doing a mandibular step back, maybe with some clockwise rotation, maybe even a mandibular step back with counterclockwise rotation, and there's just a bunch of interferences, like the proximal aspect of the distal segments, causing so much interference that you almost can't even get their occlusion into the splint. Like you're like, why can't I get the posterior teeth to touch? Like, what's going on? And you think there's something wrong with your splint, or maybe the scan's wrong, or something like that. But most frequently, it's a bony interference, and so managing those bony interferences and those class 3 movements is typically the wise thing to do prior to running into those situations. And I think that's similar to midline.
yeah, no, I mean those interferences. That again, that's just par for the course. I mean, you got to deal with that in Sages, but I'm talking about at the midline, like removing interferences at the midline. Um,
Oh, I see what you're saying. You weren't saying about the SAG interference.
no, no, no.
No,
I
the
mean at the
interference
actual
midline.
midline.
Yeah, yeah, yeah,
That's a new concept to me that I hadn't really thought about. I mean, make taking the taper fissure burr between the segments in some ways makes sense below the teeth. Now between the teeth, I'd be a little
for sure.
nervous, depending on the amount of interdental space, interradicular space I have there.
Well, because the oscillating saw removes bone, right?
Yeah,
Like it removes some degree, whether it's a quarter millimeter or half millimeter bone, whatever the thickness is. I assume it's half. And so if you put them back in the splint to where there's the interference, then you just cut the interference. And so then you've just relieved a half millimeter, and then you can just do that a couple times. It's like when you're impacting a subapical, like how do you really relieve 100% of those interferences? I just think that like running the saw a few times through there helps out. Maybe
makes
I'd be
sense.
interested to see what other people think. I
Me
mean,
too, because I wonder how much it matters. I mean, you say things like interferences, and immediately in orthodontic surgery, you're like, gotta get rid of those. Like that's a big deal for passive fit adaptation.
yeah.
Getting your plan. But I hadn't. Yeah, I'd have to think about it a little bit more myself at the midline because I mean, if the teeth are fitting into the splint and you've got fixation, I mean, it's going to heal. And so I'm wondering.
But what you're seeing is the buccal aspects of the teeth, right?
Yep.
And so how the mandible makes up for those interferences is it just gets more flared at the inferior border, which pushes the lingual cusps down. So it would just have like more lingual crown torque essentially. In maybe a few degrees, probably a few degrees doesn't make any difference. But I think in big interferences, coming up with some plan for it might be a good strategy.
I mean, are you doing that more in when you widen or when you narrow? I mean, it seems like the location of the interference would clearly
Why
be different.
widening interference at the midline isn't a thing
Yeah.
because
I'm
it's like inferior
wondering,
border, which is easy to manage.
yeah, most of my experience comes from narrowing, and I wonder if there's,
I would bet if you did the post-op superposition to your cone beams on a narrowing plan, the occlusion or the arch, that sort of thing was able to be carried out. Albeit a little bit of tipping for the teeth. But I bet the mandible is moving different than what you think.
Hmm.
Because
Interesting. I hadn't thought about it, to be
I
honest.
mean, the other part is the tubercles there, right? Um, not to forget about the old tubercles. If you have a bunch of interferences, just cutting those off probably a bad game plan. So designing the cuts a little bit differently might be a good idea.
Makes
Another
sense.
argument for a chin there, by the way. So just putting the plugs in for chins, even though adding a chin to the mix might overcomplicate it. But
Yeah, that should probably not be people's first rodeo as far as this goes, adding
yeah,
that level of complexity.
yeah.
So
But
then
I
you mentioned earlier that you advocate for a step when indicated, so just to be clear to the listeners, because I've discussed this before, all of my experience basically came from going straight down the midline because it was planned. Every time I've done it, it's been kind of planned orthodontically. We create root space between the centrals, do it that way. What you're saying is, depending on the scenario, wherever there's interradicular space in the incisor area is kind of where you would target your interdental osteotomy, but then you would carry it to the midline of the chin. Is that correct? Am I summarizing that correctly?
yeah,
Okay.
yeah. Because I mean,
Why do you, and then you mentioned that you felt it was important that it be carried to the midline. Why? I don't know if you said why you feel that way or explained why you like it that way.
I have that opinion just based off of doing it the other way. So it may be everyone's game plan to do a segmental LaFort mandible, right? Like we're planning two jaw, but then something comes up to where you can't do an upper jaw. And so you're doing this in the mandible only, and you're doing a midline mandible, let's say. And so there isn't necessarily space between the centrals, but there's a 1-2 or a 2-3 space that you can make the cut safely. If you cut straight down, then the mandible widens in a weird way, and then your fixation is asymmetric. So the inferior border fixation at the midline doesn't catch your eye because of the asymmetry of it. And even if you're off the midline, if you're on the concavity of the chin, um, you can hide it there a little bit better. But from a pair midline cut, the mandible seems like it has asymmetry to it. And so making it to where it's not just straight down the mandible. I mean, you can obviously, but it's just all the inaccuracies with interferences cause everything to widen, and you'll be widening things asymmetrically.
Makes
And
sense.
so cutting down and then making a bit of a step, if you're narrowing is going to be complicated, but if you're widening, it should be not any worse off.
Okay. So then when you do that, do you have any landmarks or anything? Are you kind of are you going about 5 millimeters? Is always the number thrown around to make sure you don't mess up the blood supply and innervation of the teeth. Are you taking that into account? Do you have any?
I mean, I think that's the usual rules apply, right? I mean, I think that's good because you have to get fixation on there. And when you do a step, where you're putting your plates a little bit different on the two segments. And so trying to leave yourself some space is useful. So I think that having 5 millimeters is really the canine. That's the problem, right? Like a 2-3 cut, it's going to be long canine. And so designing your fixation around that to some extent is going to be the trick. And it's very like just dependent on the scenario. But I think remembering where the canine is, just remembering that you got to hold things back together is the right approach. But and again, that's just from seeing people after surgery and getting some feedback on fixation and asymmetry and going back and taking out hardware.
Yeah, so
It might make a little bit more of a sense to make a step.
I have a couple of these coming up, and one of the things I was thinking about is how much you advocate for minimally invasive orthognathic surgery. So it leads me to my next question. So if you're not doing a chin with one of these, do you still make that same kind of degree of incision as you would for a genio, or do you kind of keep it more narrow and maybe tunnel more at the inferior border to just be able to put your plate on? Because it seems like if you're just making a midline or paramidline cut, you don't need
Oh yeah,
as
you don't
much
need to like
access.
dissect out the foramina or anything. Like
Yeah,
I don't know why you would need to have those landmarks at all.
right.
Yeah, like I mean, you really just dissect for the fixation. So if you're um
So when I
yeah,
put
I
my
would
endoscope
probably
in there, advocate for on this.
What's that?
When I use my endoscope for this, as you advocate for,
I mean, like honestly, the incision is going to be small no matter what you do. I think keeping it separate from your sagittal osteotomy incisions is probably the
right?
trick. So you just don't have one mega incision in the mandible. So not doing that, I think, would be the preferred technique. Just because I generally think closure of that's a little bit of a trick. And I don't know. It's I think endoscopes getting a little crazy, but definitely incisions, you don't have to get big on chins. So
What about custom hardware here at
you're
this?
just
Are
like
you
just trying to get me going again. And I know you just bring up these topics to get me on those things. I think um midline, as soon as you start adding segmental surgery to the mix on patient specific hardware, you need to start being able to carry out the plan. And so you need the ability to troubleshoot and interfere or manage interferences during the surgery. And you can't be totally wed on hardware on the outside of the mandible fixing all your problems. So um, I would have a hard time, even a harder time than usual, spending money on a custom midline plate. Um, so I don't know.
um,
I think normal fixation. I think lag screws are neat here. You should try out some lag screw fixation. Have you used that in a
Man, it
while?
has been so long since I've used a lag screw. I've considered just putting in like an inferior border plate and then like a positional screw though, or
Yeah.
two. I
Yeah, I
mean,
mean, because generally when it comes to widening your plate, the screws closest to the osteotomy are very commonly monocortical screws. Like even if you want to put bicortical screws in, you got to like tip them way out, right? Like
yep,
if you drill perpendicular to the plate, you will only engage the outer cortex
for expansion.
for expansion. Yeah,
Yeah,
exactly.
if you're narrowing, usually less of a problem.
But I mean, it's still a problem in that you're going to engage the lingual cortex potentially on the other side of the osteotomy. And so, just like getting the screw through that sort of thing. So it might make sense to just put two plates with just monocortical fixation. So yeah, it's all trauma. So yeah, I look forward to hearing from you in your upcoming cases. But midline
Yeah.
should be in everyone's repertoire. I think it's a good intervention.
Well, the last thing I was going to mention to you that we've discussed, but I think other people might have this as a question, is the intentional lingual plate fracture to help deal with the interferences that you get from expansion or from even a big advancement. And
The sagittal
yeah,
interference,
so
split.
intentional lingual plate fracture of the proximal, or sorry, the distal segment to help with those interferences. You've mentioned to me that the reason you have hesitancy over that is you feel like you could lose screw fixation capability, and then you're relying purely on a plate or plates. Um, so
Well,
yeah,
no, I don't think I'm opposed to it. I
no,
think,
no.
yeah, like I got derailed earlier in our talk. I was thinking we were talking about interferences at the sagittal osteotomy sites, but
Mhm.
now we're on that topic. The interferences at the sagittal osteotomy sites. I mean, if they're out of hand, you got to do something with it, right? Intentionally breaking the lingual plate, you just got to be careful about the lingual nerve. You got to be careful about just getting that thing either in fixation or removing it. And so, a lot of times, like the 3D mandible we had up, that thing's thick. I mean, you can remove a lot of bone there. It's really just kind of like the thin ramus interference, right? Like you just have straight cortical bone. Because you're going to remove it with kerosene or rasp or however you do it. And so taking the lingual plate off, I think is a good strategy. Makes it a lot easier.
Yeah, it seems like it would have a applicability to the scenarios that we're discussing here. And what we've discussed is trying to do it more distally, which can be more difficult to access, but so that you could still get maybe 1 to 2 positional screws distal to the second molar or whatever the most distal tooth in the arch is without skewering a tooth or roots, but also get some added fixation there. I think with piezo, this might be one of those instances where that can make things a little bit easier on you because, yeah, otherwise you're trying to take a tapered fissure burr or a saw
Sure.
back there. And I think that's nerve-wracking for most people, myself included.
Yeah, so in this scenario, this case that we were talking about, I mean, if you take off this part of the or fracture or remove this part of the lingual segment. The bone overlap, that's still an overlap, is this area, right? You can still graft this spot. And so there's still reasonable bone overlap, I think, overall. And I know reasonable is just like totally subjective. But if you took off that segment, there would still be room for a positional screw or two in relation to where the second molar is, right?
Right.
But not everyone's that way. And even though your plan for a sagittal osteotomy can be something, how that actually happens can be different. So,
Yep.
like just taking all that into account, I think interference management back there, I remember that being like the worst part of sagittal osteotomies and fellowship. Like I just disliked interference management. It was just like, can we get done with this?
Were you guys
Now
mostly using just removing? You weren't doing much lingual plate fractures?
I don't think we did. I mean, on occasion there were, like definitely it was a consideration. And obviously things could have been going on that I wasn't quite grasping because of my level of education,
Right.
because when you're a fellow, you don't certainly don't know everything. Once you're in real life, you don't know everything. But I think intentionally doing it, I don't have a memory of that being a frequent thing.
Yeah, I mean, and for people who aren't familiar with that, that may be, I don't know that it's a full topic for another day, but there is a paper that Ed Ellis published years ago. And if I remember correctly, he indicated that that was basically his go-to technique. Like that's just standard for him at this point. It could have changed since the time of that publication, of course. But I was under the impression from reading that that's he mentioned and discussed a progression of it happened on accident or something, or he thought of it and then he did it and it worked well. And then he started doing it in select cases. And he was at first doing what you said and like trying to fixate that segment. And then if I remember correctly, he said that he no longer fixated it. And, he reported good numbers of just intentionally fracturing it, trying to keep as much periosteum, attached to that segment. And he didn't really refixate it.
I mean, generally, lingual plate fracture is not that bad of a bad split.
Right.
Because I mean, it's just really changing the way you have to fixate things. So, um, but you're already putting plates on anyway. So,
But the benefit would be potential benefit, I guess, would be as you're talking about, if you remove that bone, you have less segment overlap. And if you can keep it and somehow keep it attached, you should have,
I mean, it's graft.
yeah.
So, I don't know. I think people have been managing these things for a long time, and interference management gets better with time. It's just once you do more of it, it gets less painful, and it's very useful,
All right.
good utility.
Yeah, I'm interested to see if we get any emails for this topic. I'm sure there's a wide array of opinions and techniques for
Yeah,
a lot of this that we've talked about. So
cool,
feels
man.
like that's a reasonable place to wrap it up unless you got anything else you want to add.
I think that's it. No, midline. I think fundamentally, segmental surgery in the mandible should should think about it as frequently as segmental maxillary surgery. So,
Hmm. All right. Cool. Well, again, that was another Down Fracture podcast, a podcast for talking jaws, downfracturepodcast at gmail.com. Did we get an old man saying in there?
I didn't hear one.
We didn't.
That's on you. I can't. We'll have to double up next week.
I mean, I had one that I thought of the other last episode, but I didn't get it in. But maybe I'll have to bring it out another time.
Two next week. Yeah, that'd be
All right.
good. All
All
right,
right.
man.
Cool. Thanks. Thanks for listening.
Have a good day.
Yep. See ya.